Good afternoon to everybody. It's a pleasure for me to welcome all of you, all the audience, to welcome also the faculty of this webinar. And the topic is anti-nuclear antibodies, practical tips on when, why, and how. Here we have two speakers. The first speaker will be Massimo Radin, which is an academic researcher on clinical pathologist, and is a member of the Ernst Young Working Group. He's an active member, very active member. And the second speaker will be Silvia Piantoni, which is an academic researcher on rheumatology from the University of Brescia, and Dr. Massimo Radin from the University of Turin. And Silvia is a member of the Patient Partnership Working Group. And I am Professor Luca Iaccarino. I will chair this webinar, and it's an honor for me. And I am a disease coordinator for UCTD. So now we can start the webinar. So I leave the podium to Dr. Massimo Radin. So please, Massimo, you can start your presentation.
Thank you very much.
Just a few words, a little technical message for the audience. If you want to ask some question, you can write your question on the chat, and I will ask the question to the speakers. Okay, Massimo, please.
Thank you very much for the kind introduction. I'm very happy to be speaking in this webinar together with Silvia. And I will start my presentation, and I will focus mostly on the laboratory side of things of anti-nuclear antibody testing. So we know that autoantibodies are very important in autoimmunity because they are the most important biomarkers that clinicians can use for their patient. Why are we choosing autoantibodies in autoimmunity? Of course, we use autoantibodies to diagnose our patients, to help us in the differential diagnosis, but we also use them for risk assessment, for example, for certain specific clinical manifestation of disease, for follow-up and management of our patients, and also in some cases to choosing the right treatment for our patient. But when we are talking about laboratory and laboratory testing, what we always have to keep in mind are the intrinsic characteristics of a test that we are using, mostly sensitivity and specificity. Sensitivity is the capability of the test to identify the true positive of a test when compared to all the patients that are positive for that test. Whether specificity is the ability of the test to detect the true negative of the test in comparison to all the patients that tested negative to the test. This has some important implication when choosing what kind of test do I need for my patient. Because if I want to choose a test that is of the first level and so to screen a large population, I need a test who has a high sensitivity because I want to identify all patients that are affected potentially by a disease. Of course, if a test has high sensitivity, there are some problems also to the test because I might also identify some patients that are positive to the test, but they do not have the clinical disease, the so-called false positive to the test. This is important because then after the first level screening, I need a specialistic second level testing, which must have a high specificity in order to identify only those patients that are truly positive to the test and that will develop then the clinical symptoms and the autoimmune disease. I am focusing on this aspect because anti-nuclear antibodies are the first level screening of autoimmune diseases and mainly connective tissues disease. But what are the anti-nuclear antibodies? They are a large family of antibodies that target macromolecular components in the cell nucleus. they can bind to various components of the nucleus, so DNA, RNA, proteins, as well as complexes of nucleic acid with proteins. So this is a large family of antibodies. Some of those are linked specifically with some autoimmune conditions, and others are more widely expressed and can be also expressed in the general population. As the name says, the ANAs are primarily found in the nucleus, but they can also be found in the cytoplasm because they can link also to cytoplasmatic protein. So we mostly talk about the nucleus ANA, but we can also talk about cytoplasmatic ANA. The technique that we use is mainly indirect immunofluorescent assay. So we coat the slide with our antigen, and we use two sets of primary antibodies to identify them. So a primary antibodies that link to the antigen, and the secondary antibodies that has a fluorophore or an enzyme that reacts to the light. And as you can see in this image in the slide, it gives a very important color that then can be detected by the technician or the biologist. As a substrate, we use F2 cells, which are epithelial cells derived for the Lung-Rix carcinoma, and we use those for two reasons. One, they have a very large nucleus, so they can easily be identified. And then F2 cells have over 100 antigens, both in the nucleus and in cytoplasm, that can recognize antibodies that are linked to autoimmune diseases. This is why the American College of Rheumatology recommend to use this technique. But of course, having 100 antigens can increase the false positive rate in the non-specificity of this test. But that's the reason why this is a first level test screening. So as I was saying, we take the serum of our patient that contains the antibodies and we put them into the slide. We then coat the slide with the first autoantibody, which contains IgG ANA, and then we coat the slide again with a secondary antibody which contains fluorescinated anti-IgG antibodies. After a couple of washes, we can then visualize with the microscope or with the help of the computer the slides and see if the fluorescinated effect is present. And then the technician or the biologist will then identify which kind of ANA is present. So the technician must be able to give two information to the clinician. First, the level of positivity. So if the test is highly positive, medium, or low positive. This is important because the level of fluorescence is given by the number of antibodies that are present in the patient sample. Secondly, we have to identify the pattern of the ANA. I will show you some example. This is the easiest pattern that we can see, and that is homogeneous. As you can see, the nucleus is entirely colored in a homogeneous fashion, and this is a highly positive sample. Then we can find an image like this, and this is the case of the nuclear dense fine speckled pattern, which is distributed throughout the interface nucleus with these characteristic speckle, which are heterogeneous in nature, so both in size and in brightness and in distribution. This is the example of the C4 pattern, the nuclear fine speckled, where the speckled are fine and are tiny and are distributed all across the nucleoplasm. This is the example of the nuclear dot pattern, which you can see countable nuclear dots, speckles, and as you can see, there are 6 to 20 nuclear dots per cell that can be identified only in the nucleus. If you are curious about other patterns, you can visit this site, anapattern.org, where you can find the indication of the international consensus on ANA patterns and see for yourself which kind of patterns are available. Of course, the pattern has a meaning because different autoantibodies generate different patterns. This is the case, for example, for the homogeneous pattern, which is given mostly by anti-double-strand DNA. So patients that suffer from systemic lupus erythematosus that express this kind of antibodies have mostly an homogeneous pattern, but is not as simple as it seems. Because, of course, antigens, antibodies can generate different nuclear patterns in our testing. And of course, we know that patients can have not only one antibody positivity, but might share different antibody positivities. Further, patients that have different connective tissue disease might have the same antibody. So the differential diagnosis, especially in the laboratory setting, is very important, and second and third level testing are needed in order to make a correct diagnosis. And this is the reason why ANA stand at the lower ground and they are used as a first level screening test. The last example that I want to give, because I've spoken about the false positive quite a bit, and I think Silvia will talk about it again, is the only case, well, mostly the only case of false negative ANA testing, and is the case of the anti-Rho SSA antibodies, which are a family of antibodies that are very important for the diagnosis of Sjogren syndrome and other connective tissue diseases such as systemic lupus erythematosus, and are the one case where the F2 cells might not express quite as much antigen for the anti-Rho SSA antibodies. And so in patients who don't have a high level of this kind of family of antibodies, the ANA testing might be falsely negative. So it is always important to put the results of the laboratory into the context, and if you have any doubts, to contact the laboratory that performed this kind of testing. But I will now stop sharing my screen so Silvia can give you some clinical example as well of the interpretation of the testing.
Okay, thank you.
Silvia,
Yes.
please, you have the podium.
Yes. Okay. So thank you, Professor Iaccarino, for the presentation, and thank you for this possibility to present this interesting argument. And I'm going to talk about the clinical relevance of the anti-nuclear antibodies after the excellent introduction about the method just done by Massimo. I could start, maybe I can, so I want to delete this. Okay, you can see the screen, or you see this?
I can see the screen.
Okay, okay, so it's good because in my, okay. I'm sorry, because I had a problem. Okay, so I could start talking about the evidence of the anti-nuclear antibodies positivity in general adult population. The prevalence of the anti-nuclear antibodies is around 20%, and the high titers of these antibodies are present in 2% of cases. The prevalence of ANA-associated disease in the general adult population is around 1%. The main factors that are associated to anti-nuclear positivity in general adult population are the use of some medication, a family history of autoimmune diseases, older age, female sex, and also an environmental exposure to silica, smoking, and UV radiation. The significance of a positive antinuclear antibodies in people without autoimmune disease is not known, and it is due to an inability to study large healthy population. So it's difficult to study clinical outcomes in a general adult healthy population. So when we don't have a disease, it's difficult to study a healthy population and to have the feeling about the importance of this positivity. And there are some studies that identify a peculiar immunological landscape in healthy people who have antinuclear antibodies positivity. Some studies, they presented elevated levels of pro-inflammatory mediators or high levels of autoantibody production. And in some studies, people with ANA positivity presented an upregulation of some type of 1 interferon genes which are related to autoimmune disease. There are conflicting results because the specificity of antinuclear antibodies that occurs in healthy people is poorly characterized. So we know that they are antinuclear positive, but we don't know exactly the specificity. And the problem is complex because the term antinuclear antibodies comprise antibodies directed at different cellular components. So not only against the nucleus, but also outside the nucleus. As Massimo said, some antinuclear antibodies are directed to antigens which are outside the nucleus. So it's difficult to identify also this immunological landscape in antinuclear positive people. So I can say that according with the specificity, there are some ANA positive individuals which are more prone to inflammation. And on the other side, we can have also antinuclear positive individuals which has a decrease of the level of systemic inflammation. So it's something difficult to define. There is a recent publication which is interesting from this point of view because this researcher studies with a bioinformatic approach, studies a lot of electronic health records of more of 70,000 individuals, and they identifying some clinical association between the positivity for antinuclear antibodies and some clinical outcomes in dividing the individuals in patient with autoimmune disease and patient without autoimmune disease. In patient with autoimmune disease, the antinuclear positivity was related to some diseases, in particular systemic lupus erythematosus, systemic sclerosis, or unspecified diffuse connective tissue disease and Zika syndrome, for example. In the population without autoimmune disease, the presence of antinuclear antibodies was related to the Raynaud syndrome, the idiopathic fibrosing alveolitis, osteoarthritis, and joint pain. So it was a nice study that confirmed previous result, and the advantage was that they study really a good numbers of individuals. Another important point that can affect the study around this topic is that antinuclear antibodies may be present for years before a patient develops an autoimmune disease. So when we do a study of population, we have a picture of that moment, but we don't know if during time people will develop autoimmune disease. In any case, when we are talking about pathologies and diseases which are associated to antinuclear antibodies, in particular, we are referred to systemic or organ-specific autoimmune disease, inflammatory bowel disease, viral infection, interstitial pulmonary fibrosis, and malignancies. Here you can find the percentage of positive antinuclear antibodies among different diseases, and we have a prevalence of 100% of this positivity in the mixed connective tissue disease, in systemic lupus erythematosus, and in scleroderma, because you can see here that the percentage is around 95 or 100%. If you look at the Sjogren's disease or other inflammatory disease like polymyositis and dermatomyositis, you see that the prevalence of the positivity of antinucleus is not around 100%, because just to say something about something that also Massimo said, there are some specific antinuclear antibodies that give a false positive result to this screening test. So when we have the clinical suspicion of Sjogren's disease or polydermatomyositis, we have to go further, despite the fact that maybe the antinuclear antibodies testing is negative. Of course, there are other percentage of positivity for the organ-specific autoimmune disease. It's more difficult to define a percentage of positivity among viral infection, malignancies, or other diseases. Is more difficult to do study population about the other disease. When we talk about antinuclear antibodies and their clinical meaning, the concept of biomarker is something that arrives in our mind, because antinuclear antibodies in fact are biomarker, because they are molecules that are found in blood, so they are circulating biomarker, and they describe a kind of condition of a pathologic process, and they are biomarker, a valid biomarker, because they can be evaluated in an objective, sensitive, quantifiable, and also easily accessible way. I have to say that these biomarkers are part of the laboratory data that, together with clinical feature and now also digital data, are important for the classification criteria and the clinimetric indexes for our disease. This is a quick introduction about the concept that I want to share with you. Antinuclear antibodies are biomarkers for the diagnosis, and here you can see systemic lupus erythematosus, systemic sclerosis, Sjogren's syndrome, and so on. They are important biomarkers for the monitoring or defining prognosis in other conditions like Raynaud phenomenon and juvenile chronic arthritis. Just to do some example, in systemic lupus erythematosus, antinuclear antibodies are, the positivity is an entry criterion. So you can consider the diagnosis of lupus only if you have this positivity. So these biomarkers is really important for the diagnosis of this disease. The situation is different for the Raynaud phenomenon, that is not a disease but a syndrome, and in this case the testing of ANA is important if there are some signs and symptoms of an underlying connective tissue disease. The detection of antinuclear antibodies has another meaning in another disease like juvenile chronic arthritis, in which the determination of antinuclear antibodies has an important role in stratifying, for example, the risk of uveitis. Some final consideration about the titer and pattern. Of course, high titer of antinuclear antibodies is more suggestive of an underlying autoimmune disease, but in isolation, the presence of antinuclear antibodies is not diagnostic. And we can say also that there are some specificity of antinuclear antibody that has the opposite meaning, because there are some antinuclear antibodies that we know we are not related to autoimmune disease or diseases like the anti-DFS70. About the pattern is not specific. As we've seen, the pattern can suggest some antigen specificity, but it's useful to go further with the analysis with other tests like the solid phase assay to detect specificity. We can say at the end that in the absence of evidence of an antinuclear rheumatologic condition, there is no anatiter or pattern that requires a rheumatologic consultation. So at the basis, we need a clinical suspicion. So the specific testing and additional specific testing are required when there is a high clinical suspicion of antinuclear antibodies related disease. So there is this importance of pretest probability. We can say that in patients with a negative antinuclear antibody test, repeated testing is usually not indicated unless there are new signs of symptoms of rheumatic disease, or, for example, an high clinical suspicion, such as for myositis, for example. And in another situation, when we define an autoimmune disease with a positivity for antinuclear antibodies, the test does not need to be repeated because there is no evidence that some changes in ANA titer in particular serve as a marker of disease activity. Just to conclude, of course, for a general practitioner that wants to prescribe antinuclear antibodies, we can say that the clinical suspicion is the first element that can induce to the research of these antibodies. And of course, for the clinical suspicion, we have always to have in mind which are the most important and the most common signs and symptoms of autoimmune disease, which are the categories of disease that are mainly related to these antibodies. Thank you very much. With this, I have concluded my presentation. So looking forward to reply to your question. Thank you.
Okay, thank you, Silvia. Thank you, Massimo, for your presentation. Very nice presentation. So thank you very much. So we have two questions from the audience. So one question is about age and sex-related changes in ANA detection and titer. I think that could be for you, Massimo, if you want to answer to this question.
Yes, of course. Thank you for the question. As I think Silvia was already telling, age and sex can be an important factor when detecting the possibility of having a positivity, INA positivity, also in the general population. So in the female sex and in older ages, the rate of positivity grows. So the chances are that a patient is more likely to be falsely ANA positive during his lifetime. Of course, how to change this is to, as Silvia was suggesting, only prescribe this kind of testing in patients in which you suggest, in which you think about a connective tissue disorder or an autoimmune disease. Also, other diseases can increase the chance, for example, other autoimmune conditions such as thyroiditis, which can be an important confounding factor. So, yes.
We have another question. With the question is, with treatment, the antinuclear antibodies can become negative. This is not so frequent in my experience. However, it's possible. And the question is, if the antinuclear antibodies became positive again, this means that we have a disease recurrence. I think that is a question for you, Silvia.
Yes, I think that we have always to consider also an aspect that sometimes some viral infections can influence the positivity of these antibodies. So when we know a patient and we know that that patient was antinuclear antibodies negative, when there is a positivity, we have always to look at the clinical situation. So if we have the feeling that something is happening, it's important to, of course, repeat the test and also doing some other exam to get the specificity. In other case, we can consider that sometimes the positivity could be also temporary. And so it's something that is described. So, and if we know the patient, it's better. The problem is always when we have to do the first diagnosis. I think this.
Okay, thank you. We are waiting for other questions for the audience. So I have one question for Massimo and one from Silvia. I would like that just if you want to summarize your take-home message. So, Massimo, do you think that it's very important to the clinician to verify in the report, the laboratory report, which technique has been used for the anti-nuclear antibody detection? Do you want to stress this point? That I think is very, very important.
Yes, I agree. It's something that I didn't talk about, but I think that it's important for the audience to understand that ANA testing is a specialized test, and there are on your territory, of course, some laboratories that specialize in autoimmunity testing, and it's important also to tell your patients to go to those laboratories because there are more than one technique in order to identify ANA testing, and some work better than others. Because as I was saying, there are some recommended techniques because depending on, for example, the cells that you're using to test the antigens, you can detect certain antibodies families or not. Also, it is an operator-dependent test. So the operators that sees the slides and the fluorescinated pattern has to give an interpretation of the test. So the more experience is the laboratory, the better. So you have results that you can really rely on because then diagnosis can really be helped with this testing. And if not, if the patient goes to a laboratory that you don't really trust, then the results is worthless, of course. So I think this is a great point. Thank you, Professor Crane.
Thank you, Massimo. Just one question to Silvia. Silvia, I agree with you. You told in your presentation that the high titer of anti-nuclear antibody are predictive for rheumatic disease. But do you think that it would be a good idea to give as a message to give a threshold of the titer? I don't know, 180, 160. Do you think
Yes.
that could be an idea to give a threshold to the audience or also to the clinicians?
I think that 160 is probably the level that as rheumatologists consider as the most clinically relevant. I have to say. For us, it's important that the laboratory staff, in any case, give us also a slow positivity because it helps in some condition. But I think that 160 is probably the threshold that I would consider as a true positive.
And I agree with you. Probably not only the titer, but also the persistence of the anti-nuclear antibodies in time. We had the question on the nuclear, anti-nuclear become negative, then positive, depend on the titer of the positivity, of course. So this is another important point to consider when we have a persistence of high titer anti-nuclear antibody. Probably these are the very predictive for rheumatic autoimmune disease. Okay, there are no further questions to the audience, so I thank both of you. Thank you, Massimo. Thank you, Silvia, for your presentation. Very nice, very useful to the audience, and see you on the next webinar.
Thank you very much.
Thank you very much.
Bye-bye.
Bye.